is located. It is the word that the first people gave observatory. And Kamirorichas, in the words of that First Nations, those First Nations, means place of the stars. But even as we reflect on this being a place of the stars, or Cape Town then being the place, a place of stars, we recognize that the country as a whole and our province as well has gone through what Dickens in the European context referred to as the best of times and the worst of times. And yet I'm quite reminded that even in that context of great struggle, Maya Angelou was able to cry out that still we rise. And I want to recognize this bill and the deliberations you're engaging in as part of that process of rising. The pandemic has dealt us a significant blow in terms of both the weight of human tragedy that we've experienced, as well as the pressure that our health systems have experienced in this time. And so as we reflect on this rising, it is important for us to engage in the process that you're embarking on at the moment. Central to that conversation, though, we reckon, is the commitment to universal health coverage, an issue which became central to the experience of South Africans throughout the pandemic. In addition, that universal health coverage idea recognizes the role of health itself and the practice of health as an important economic stimulus to building a nation's economy as well. But importantly, in the pandemic, what we have experienced, and as a portfolio committee, I would recommend that we never lose sight of, is this broader swathe of things which affect the delivery of healthcare to people. That affect their level of health status in terms of the social determinants of health, which I'll return to a little bit later. In recognizing Professor Klova as a member of the executive committee, I do want to just note for this meeting that I've just come on board as the chair of SACMD, of the South African Committee of Medical Deans, and that is a chair which happens by rotation. So effectively, UCT is the chair at the moment, and the deputy chair is Professor Jabu Mbogazi from Walter Sisulu Faculty of Health Sciences, and Professor Ngoza Klova is the additional member on the executive. And it's really just to locate this in that collective of universities who train medical students. Chair, I'm going to share my slide now, so there'll be a bit of a pause as I ensure that everybody is able to see that. So I apologize for the interruption there. Chair, is everybody seeing the slides at the moment?
Yes, we can. Maybe just put a slideshow, please.
Okay. Are you seeing the slideshow?
There we go. Thank you.
So Chair, one of the things that, what we've done on this first slide is really put the emblems of all of the 10 universities that are represented in the Committee of Medical Deans. It's a group of 10 universities who train medical doctors and specialists in the broader context of a higher education environment. And I thought it would be important to share a little bit about our context. Last year, at the beginning of this year, 2,541 medical interns were delivered into the health system and allocated to jobs, albeit through a very fraught and difficult process at the central and provincial governments. 1,889 of those would have graduated from local medical programs, including the first batch of graduates from the University of Limpopo. And I think we're very proud as a committee and a community of practice for the support we've been able to offer the University of Limpopo, and proud of their work in delivering the latest cohort of students into the intern system. In addition, Chair, I want to just emphasize that part of that cohort of 2,500 interns are 594 Nelson Mandela Fidel Castro candidates who completed their final year of training. They spent 18 months with us in local higher education, in our universities, in fact, for the last 18 months. And I raise that because What we have done over the last year since we have formalized the structure of the Committee of Medical Deans, we have foregrounded our collaboration with the Department of Health in achieving an ideal environment for both the training and the training of healthcare professionals and for the delivery of health services. Last year, through the college as a unitary examination process, we delivered 1,117 specialists across 35 different specialties. And the reason for that, what looks like a bumper crop, is probably inflated by about 200 because there was no second semester exam at the end of 2020 in that year where exams were being reconfigured and processes of examination was changing. 209 subspecialists qualified in 2021 as well. And that represents something which I will allude to a little bit later in our reflections on the intersection of the Human Resources for Health Plan 2030 with the NHI process, and something that we feel needs to be harmonized to some extent. I want to also just inform the committee that as the 10 of us, as the Committee of Medical Deans, we are also members, all of us, in different through different structures of the South African Committee of Health Science Deans. That would include upwards of about 20 universities across the country who teach the health sciences but don't have a medical program. And then there's a parallel committee for the South African Committee of Dental Deans who also train health professionals for the healthcare system. I trust that the committee has engaged with those separately. And then we have become identified by USAF, the University of South Africa, as part of one of their communities of practice, and we receive admin support through an engaged commercial arrangement with USAF. So that's the context in which we are. I want to emphasize, Chair, though, that the submission that we've sent to you from the 2019 submissions has been interrupted by this time of pandemic. And I want to make the point at this stage that we have not really been able to engage with any depth with what lessons we have learned in the COVID period, in the time of pandemic, that may well inform that NHI process or the universal healthcare coverage that we were all aiming to achieve. And I make that point now because I have no doubt that all of us as universities with medical programs recognize that the pandemic taught us many good lessons. It also raised many red flags about how the system struggled to cope. In fact, the fact that we got through it to some measure is a commendable state of affairs. But I want to recognize the fact that there have been lessons that we could easily apply to the health system as we go forward. Chair, the structure of my presentation today would be really to highlight the key issues that came up in the document you submitted in 2019, but then to make a couple of comments only on the bill itself, because we recognize as well that each of our universities have covered the technical aspects of the bill to a large extent in their individual submissions. And so what I want to do is go very lightly into the detail of the bill and then stand back and talk a little bit about the things that we think may need to be included in the bill in order for it to cover all of the domains of healthcare and practice. So these were the key issues that our submission in 2019 covered. It spoke of locating the National Health Insurance Fund in the broader public healthcare delivery system. And again, we will come back to this in various forms later on, the tension that exists between the National Health Act, which essentially is the governance, gives us guidelines for a health system, and the question of the National Health Insurance Fund, which uses a fund process, a financing model as it has unfolded. Then the idea that the National Health Insurance Fund should be located in the context of the two-tiered national healthcare system, with particular attention to the private healthcare system, the private health sector. And then speaking to the issue of design and governance of the integrated healthcare service delivery system, which I think is an ideal process to go to. Locating academia and the health professional training platform in the national health insurance context, I will refer to, because one of the things that we have found in our rereading of the bill again is the fact that the dearth of connection between the higher education institutions and the training imperatives of healthcare professionals in the fund, in the proposed legislation. And then the governance of the National Health Insurance Fund. I think we're making some comments in that regard in the course of our presentation. I want to highlight a couple of things in terms of the comments on the bill from our responses to the preamble. It's recognizing that in the first instance, the general public health system and the private healthcare system is in need of serious attention in order to strengthen it. I think that in our comments to you, you will note that it's not an either or, but it's a both and. The concept that we have to be very intentional about the strengthening of the public health system. We have recognized over the last little while the significant reports about the challenges within the health system, not least the reports around the Eastern Cape, the situation in the Eastern Cape, and also the situation surrounding Charlotte Maxeke Academic Hospital in Johannesburg. And then we've suggested the addition of a clause address the social and economic determinants of health to promote health and disease prevention through intersectoral collaboration and strengthening of non-personal health care. So Chair, this statement, I think, is almost prophetic of the challenges that arose during the pandemic. My sense is that we have to recognize that the solution to health problems is multisectoral. And while the bill looks at a funding process, we need to foreground increasingly the fact that a health system must recognize those components which render it part of a preventive process as well. And so this is the only slide I want to refer to in terms of the comments on the bill itself. I want to pick up a couple of things that have come through refreshed comments from colleagues over the last week. I think I've made the point quite strongly now about the extent to which the strengthening of the healthcare system is importantly linked to any attempts at an NHI process. And we recognize that in the health system, there are a number of problems. I want to say that the problem primarily is burden of disease, but I do want to argue that the areas of governance and management are equally at play in not allowing our people to enjoy adequate access. Colleagues have commented on the tension between purchaser and payer. The idea is that those concepts need to be further explicated in some way, and I think that has been raised in many of the university's individual submissions, and I won't dwell on that much longer. I think that perhaps the important thing now at this juncture, 3 years after our submission, or 2.5 years after our submission, is the necessity for us to try and make sure that in the writing and the editing of the bill now, that we become very aware of the provisions in the National Health Act versus the provisions of a funding mechanism, which is what the NHI fund bill seeks to do. I also think that the National Health Act is quite an ambitious spread of what we wish to achieve in healthcare. And I think some of the lessons that we've learned in the COVID period are important, not least of which is this question of registration. I think in the vaccination process, we recognize that registration prior to the access remains a challenge in our situation. And I think we could have long conversations about its impact for vaccination. I want to pick up a couple of things that we mentioned in the first submission surrounding the language and what may be interpreted as as the language around asylum seekers, undocumented migrants, students, and all children. And we reckon that the language that is used in terms of access needs to be quite clear and more inclusive than less inclusive. Again, we want to speak to the ideas that the processes of appointment of people and the seats of power in the governance process need to be attended to. We've made comments in the submission around Excuse
me, Chairperson. I just want to find out where the slide is not moving, but there's a lot of very vital information that is discussed by the presenter. Is there maybe a problem somewhere? A lot of important information is discussed here, but there's only one slide here, and it doesn't have the information that he is discussing. Can I ask that, Chairperson, through you?
Yeah, Honorable Chair, I agree with Dr. Tembegwayo, so that at least we see the content of the slide. Otherwise, we can't connect, which makes us very difficult to connect with the Prof. Green Thompson.
Chair, if I may.
Yes, Professor.
So, Chair, the slide hasn't moved because this is the only slide that I will show on the comments on the contents of the bill. What I'm doing is really paraphrasing the contents of our submission to you, which we sent to the committee last week. So I'm sorry if my intention was not to put everything I was going to say into a slide, because it's really a modification of what is in the presentation we submitted.
Yes,
in fact,
yes,
the presentation is more extensive than my presentation.
Thank you, Prof. That's what I understood you to be doing also. Please continue.
I see there's another hand, Chair. I'm not sure what process is.
No, I think that is the legacy hand now.
Okay, thank you.
Honorable Bunyayi, I think that's your legacy hand.
No, all I want to understand, when did the organization of Dean really requested to make presentation before the NHI? If they can clarify us, please. When did you make such a request to present before us?
Chair, may I?
Yes, you may.
So, Chair, this presentation is by invitation. We were asked to make a submission which was submitted on November 2019, which is a document we recirculated to the committee last week. But we're recognizing in this presentation that there's been a significant shift in the healthcare landscape in that period. So we've not requested this presentation, it's by invitation.
Thank you, Prof. We do understand you were part of the initial group of people who had made submission. Based on your submission that was made in November 2019, you were invited and you had indicated you wanted to do an oral presentation, which then based on that, because we have invited all of those who had made such indication as to us being transparent and fair, you've then been invited as the South African Committee of Medical Deans to come and make your oral presentation, and you had requested a postponement, which was granted, and now today is your day for presentation. Please continue with your presentation. Thank you.
Thank you, Chair.
Sorry, Chairperson. Can he display what he is reading rather than putting this short version? Can he display what he is reading? Because he is reading from some slides. Can he display them, please?
Honorable Tembegwayo, I understand what Professor Green Thompson is saying, and it has happened before. And in any case, one does not read from a presentation. What I understand the professor is doing is that he's presenting a slide and he's talking around the slide, giving us more than what is on the slide. Is there any way, Professor Green Thompson, that we can see it or be sent whatever you're talking, whatever you're talking on now, whether it is on a soft copy or something that we can find or get from?
So Chair, I mean, I'm hoping that, I mean, if we can get the recording, we'll try and transcribe what I'm saying. The point I made at the beginning is that I was limiting the comments on the bill per se, because many of our members have sent detailed comments on that. This was the slide, the only slide on the comments on the bill particularly. The remainder of my slides, to which I will move shortly, are slides that refer to the things that we think should be in the bill that I will spend the majority of my time on. What I'm currently doing is really just contextualizing our previous submission. And so it's very difficult for me to go word for word through that submission, because what I'm doing is really, I'm using more a lecture format than an information presentation format.
Yes.
Because I assume the document to have been read.
I agree.
And my apologies that I don't have enough detail on the slides.
Yes, my apologies also. Please continue, Professor Gatos.
So Chair, again, and maybe what I will do is just refer to the pages of our document then, from where I'm taking the comments, because that's not they're not in a presentable format. So on page 7 of our document, where we refer to page 9 and 10, there was quite a discussion about the fact that we need to enhance the areas of quality assurance and ensure that the appointment of quality assurance bodies needs to be enhanced as well. And then we've spoken about the functions on page 8 of our document. Then we refer to pages 11, 12, and 13 of the submitted document. We speak to functions of the fund and powers of the fund, but that what we're really emphasizing there is the need for us to distill the powers and functions described in the bill to very specific ideas, and then also to enhance the idea that not all the power or the authority rests in the minister, but that they become a more distributed process through which accountability can be enhanced in the system. And then one of the comments from a colleague was really about the idea of concentration of power currently proposed is often unregulatable, or maybe unregulatable, because of the way in which the bill constructs that power authority. On the page 9, then pages, and I'll make very short comments on this, pages 13 to 14, we really speak to the processes of appointment and establishments of board, that these should be appointed. So the board should be appointed by an appointment process or nominations process that we have seen in other structures in the health system, and that we separate the appointment process to a more open and independent process. And then officials in the fund itself, the CEO and CFO, should then become appointed by that board in effect. I'm going to skip in the written document a couple of pages, colleagues, and then speak to the idea that there needs to be clarity in the writing up of the functions of the technical committees as to whether these would be members of the board or whether there would be other people brought onto these. And the concept of fit and proper has come up in the comments of the committee members, but that we focus on the idea that people should have the appropriate experience and be beyond reproach in their engagements. On page 12, we make some general comments around governance, and they really are further comments around transparency of the committees and making the recommendation, in fact, that civil society should be represented on all committees. It's not clear the extent to which patient advocates would be represented in the system as currently described. And I think one of the comments that we've made is the shift of the two documents, the white paper and the bill, the two offerings from the department moving from a service to a funding model, and that perhaps there needs to be a reclaiming of the original ideals of service in the earlier document. And then there are a number of comments, colleagues, around the areas of the administrative parts of the system. We want to make a general comment on chapter 10, and it's on page 17 of our submitted document, that we really have to recognize absolutely that universal health coverage is the only way forward for South Africa. That the NHI bill is recognized by committee members at the time of submission, that the bill in itself is sound, but that there are serious questions that need to be reflected on if it is to be arranged in a way that will have the desired impact without a detrimental impact on the health system. Colleagues, that's pretty much what I want to leave the conversation at around the content of the bill itself. I did want to pick up a number of things in the area, in that section C of our document, which are the things that are not addressed in the bill. And so we're suggesting that there needs to be an additional chapter which deals with health professions education and national structures such as universities, and particularly the NHLS. Your committee must be very familiar with the struggle that the NHLS has had across the South African health system in attempting to deliver services in more remote areas, but that we need to be very careful that that district health management office significantly has a change management process, so that in our breaking up to build up, we don't lose and create a negative impact on the health system. But I think that what we want to recognize is that, in fact, the health system has got to build the primary healthcare entry point and promotion of health as that entry point for healthcare. And if we're able to achieve that, we recognize the huge savings that will achieve. But I think that what we have to do as we ask that the bill reflects on engagement with the university, we find areas of mutual interest, particularly around training and the quality of health services, which essentially is the thing that we would see ourselves as sharing an interest with the general health system. In addition, the submission refers to the call for a new chapter on academic medicine and health professions education. And here, colleagues, we refer to academic medicine perhaps from an interest point of the medical committee of medical deans, but recognizing that this academic medicine is an academic discourse that covers all of the health professions. And so I want to just emphasize this is not a call for exclusively medicine, but probably academic health care. And then we really want to foreground through the NHI perhaps a deepening sense of the participation in fundamental and important change in the healthcare system. My apologies for that malalignment there. And that the bill should support and enable the work of universities. And we're recognizing, as I've mentioned a little earlier, the fact that in the early iterations of reflections on an NHI, service seemed to have been more foregrounded than the funding as has happened in the latter documents. But we need to make sure that the bill and all the regulations support the academic institutions, which will include technical and nursing colleges, to achieve that goal of training healthcare professionals for a healthy and wealthy society. And this notion of a healthy and wealthy society is an important idea because health is such a fundamental part of a robust economic framing. We ask that what needs to be inserted is greater reference to research and the academic enterprise. It's really important that research is foregrounded, and some of the things that many of us as deans are beginning to say, that the learning enterprise is embedded in the service enterprise. The learning and research enterprise is embedded in the service enterprise, and vice versa. We want to foreground this notion of professionalism, and I think the bill does speak in some way to the extent to which we need to professionalize the health people in the healthcare system in general. But I think I've made the point sufficiently about academic principles in the bill itself, because again, we believe that the research that is embarked on by universities informs the health system, and often the health system informs the extent to which research is possible. But really that every clinical encounter, I want to change that to medical, from medical to clinical encounter, is an opportunity for training, innovation, and monitoring. We speak about the role of higher education participating in the various advisory committees, but just make sure that the way in which this happens is recognizing the role and the resource that the academic platforms will have for the health system. There again is that very tense space of recognizing the role that we may be able to contribute with the autonomy. And I recognize that is often viewed in different ways from different perspectives. And then I've added here, so I've moved this from late in the document, that we have to talk about training posts. There is a vigorous conversation happening at the moment nationally about the training of specialists. There's significant conversations about how some provinces are treating registrar posts. And there've been questions from the environment within Natal. But this idea that we consciously build training posts into both the Human Resources for Health 2030 strategy, as well as recognizing them as a significant part of the funding requirement from a healthcare system, I think will also be able to be dealt with in the new chapters that we're suggesting. So just a couple of focus issues that I think would facilitate the process, and we've mentioned them in our submission. The idea that higher education and government need to meet and just develop a common understanding of what that Human Resources for Health 2030 strategy, which was released after our submission. But I think it's an important guide for determining both the shape of the healthcare system and the extent of the investment in the training of health professionals. The sustainability of providing sufficient healthcare professionals of good quality and appropriate relevance really depends on a quality and stable healthcare system. And while we recognize that it needs repair across the board, I think that we can contribute to sharing that work. And so we come in the spirit of this presentation in humility to recognizing our collaborative engagement around these things. The central hospitals versus academic complexes idea, it's an issue that has occupied the Committee of Medical Deans in various guises over the last years, beginning to recognize the fact that academic complexes then are things that can happen if we're going to recognize every clinical encounter as a learning, research, and innovation moment, then we have to recognize that academic health complexes may be a much broader idea than central hospitals, but we recognize the recognition given in the bill for central hospitals. In order to achieve that promotive environment, I think that we accept that public health entities should be strengthened. The question of pragmatism, and we may not have all the answers. We are offering thoughts that we can continue to engage around. But I think foregrounding the question of an NHI process and universal health coverage process that's integrally linked to the commitments to training is something that we have to foreground in the process. I'll refer to the HR 2030 strategy plan and what that means in the broader environment. And again, that's an insertion that has come since our submission in 2019. The JSEC is a process that the Committee of Medical Deans has engaged with, has tried to engage with significantly over the last while. and it hasn't really been a successful body at this stage. And the intention of the structure originally was that it brought together the Department of Higher Education. I think it's included Science and Innovation now. That department, which is responsible for the educational mandate, the Department of Health, which runs the health mandate, and Treasury, which funds all of these activities. That if we can strengthen the JSEC to formalizing these collaborative spaces, I think we go a long way in terms of what we can achieve, both through the NHI and through the health system more generally. I made the point that the document makes the point about the important collaborative role for academic institutions, integration, and make sure we can be defined as partners in the technical partners in the processes. I'm mindful of the time, Chair, but I want to just make a point here that we think that the academic institutions can bring a technical expertise to the conversation that can enhance the conversation that the NHI triggers, and I think it is a really important and valuable conversation. And I think we can use the capacities and the scale of universities in that way as well. We've spoken, I think these aspects are self-explanatory, these bullet points. I think one of the things that we have achieved to great measure as an impetus from the COVID experience, the pandemic experience, is the sudden escalation into a fourth industrial revolution and artificial intelligence environment. In the past, where teleconsultation was a huge debate in the professional organizations, suddenly those are accepted as billable events and things that people can engage with legitimately without compromising care. And then the issue of what is going to be the role of the provinces. How do we manage, how does the bill intend to manage the current structures of provinces where there's significant power bases in terms of distribution of funds in the provinces? So colleagues, that's our presentation. I really want to express again the thanks for the invitation to present here. And I really do want to say, and I'll invite my colleagues if they would like to add any particular comments at this stage before we take questions. But I really want to make a note that we really do come in humility to this conversation, recognize that the shared vision of the health of our people is an important ideal to seek and to establish. So thank you, colleagues. I don't know, Professor Clover, if you're still here, I know you had a limited availability. Chair, if I may call on my colleagues to make comments.
Certainly, you're welcome.
Thanks, Professor Green-Thompson for representing SACOMT, and thanks to the colleagues also for allowing us and giving us.
Honorable Chair, I don't see the presenter. I don't know whether it's a network problems. I don't know. And I don't know who the presenter is now.
I think, Nwaza, you'll have to show your face.
Names, please.
It's Professor Nwaza Clover from UKZN.
Hi, colleagues. My name is Professor Nwaza Clover. I'm a hematologist by profession, and I'm a full professor at UKZN, and I'm the Dean and Head of School of Clinical Medicine at UKZN in Durban, South Africa. Do you need more information about me?
That's fine enough. Thank you. Continue.
Yeah.
Honorable Chair, we don't need any other, we just needed to see the prof and the names only, like we did with other presenters before us.
Please recognize, I don't know whether we are professor or what, Mr. Chilidzi, that the network becomes a problem when we have to show our face. So that's why we don't show our face. Otherwise I get cut.
I'm not a professor, I don't wish to be. Thanks.
Thank you. Through you, Chair, again, I want to reiterate Professor Green-Thompson's sentiments in terms of, our to this association and partnership and engagement. We humble ourselves, we want to find common path and see how we can work together as South Africans and as to ensure that we provide the best service for our citizens. So I just wanted to add that in particular, what in some of the items that Professor Thompson has mentioned, more of concern specifically to us at UKZN is the reduction in the number of registrars, which has really created a massive negative impact in the way we run our establishment. Our registrars have been reduced from a number of 400 registrars 5-7 years ago to about 150, 200 registrars. I may just need to get the exact numbers, but this is really straining the running of the medical school and the clinic. So we would really appreciate your support in this regard. I'm not going to be long, Chair. I will be here. Thank you so much. And thanks once more, Professor Thompson, for your presentation.
Chair, there's also Professor Rezenga Chauke, who's in the meeting as the Dean from the Sefako Makgato Health Sciences University. I'm not sure if he has any comments to make at this stage.
Through your chair, thank you very much, Prof. Grim Thompson, and good morning, honorables. Indeed, we reiterate what Prof. Grim Thompson has presented to this portfolio committee. We believe that NHI is the only way to go for our country. And we think that strengthening health institutions, particularly training institutions, and looking favorably at the historically Black training institutions will go a long way in producing healthcare professionals that will fit into the program of NHI. And we believe that by taking cognizance into what we think is missing in the bill will go a long way towards strengthening what we think should be the health system in the country that should not discriminate rich or poor, young or old, Black or white, and so on and so forth. So we think, we believe in the bill, and we believe that further engagements in strengthening what we think are weaknesses within the bill will assist the country in achieving the universal health coverage for all. And this is what we stand for as Deans. Thank you very much.
Thank you, Rezenga. Chair, if I may just introduce the last member of our team, Dr. Kieran Begg, who's a public health specialist and serves as a Deputy Dean for Undergraduate Education here at our faculty. Just short comments, Kieran, and then we hand back to the Chair for questions.
Thank you very much to the committee, and thank you to Professor Lionel Green Thompson. I think the only addition to add is just the emphasis that, in fact, universal health coverage is what our universities have been looking for a long time. And we teach that to our students, both undergraduate and postgraduate, so that as they enter the healthcare system, that they have an expectation of what is expected to provide health for all. And so we stand with those principles very strongly. And I think that all four of us have indicated that. And every single one of the faculties of health sciences would indicate the same. Just that we've identified some of the gaps and insertions that we think would be helpful for this going forward. But once again, we come in a space of cooperation and collaboration that as we train, the lead time is extensive for us to be able to shift the healthcare system, and that we really would like to be part of that engagement, and that the clarity around training of health professionals, which does take an extensive period of time, that is taken cognizance of in the broader bill and any additions going forward. Thank you so very much, colleagues.
Chair, thank you. So we're happy to take questions. And my colleague, I don't think another dean joined while I was presenting, so I think that's all of us, Dr. Jacobs.
Thank you very much, our esteemed learned professors and academics from our universities and our medical schools for this presentation. We have a number of members who would like to engage with you, and I'm going to name them in order. It would be Honorables Ismail, Sukacha, Gela, Munyai Tembakwayo, Ismail Sukacha, Yela Munyai Tembakwayo. If there are any other members whom I have not noted and would like to raise some questions or concerns or speak to the presenters here, please shout on the platform if I've not noted you on the WhatsApp group. Honorable Siwela, I see an Honorable Harvard, so I'm going to make number 6, I'm going to make Siwela, and number 7, I'm going to make Honorable Harvard. Any other member? You may continue to raise your points and questions with the presenters, honorable members.
Thank you, Chair. Thank you, Chair. Good morning to everyone. To Deans, thank you for a very, very interesting presentation. I have a number of questions. My first question, would Deans recommend that the governance of specialized hospitals remain with provinces? My second question, does the bill address social detriment of health and preventative strategies? What are the implications if these items are not addressed? My third question, you highlighted that the minister is basically a political appointee and independent oversight is important. Do you recommend parliamentary oversight to improve the accountability and legitimacy of the board? My fourth question, to what extent does the bill allow for equal access to quality healthcare? You have stated in your presentation that the first version and the second version is actually, not talking to each other. So in your opinion, is this an all-inclusive bill? How sustainable is this bill in its current form? Now, would you say that the NHI bill in its current form will be providing a health value-based model? My fifth question, do you foresee a rise in immigration of healthcare workers out of South Africa as soon as the NHI is implemented? My sixth question, has the department adequately planned for the NHI? In your opinion, taking into consideration that the pilot projects were not even an effective tool for establishing whether the NHI will work, or do you think we should have further pilot projects, with specifications relating to the NHI to first see if this will actually work before overhauling the whole system? My seventh question, do you feel that with the current shortage of healthcare workers, especially considering placements and with the infrastructure crisis we're experiencing right now, do you think NHI will really work? Or do you think we should first address in improving our healthcare infrastructure and, we increase the amount of healthcare workers in the system before the implementation of the NHI? Now, you've touched a little on the single purchaser, single buyer model, but you haven't, specified. I'm just going to ask a very simple, straightforward question. Do you feel that a single purchaser, single buyer model is going to, cause a monopoly, thus increasing prices of medicines? We know that presently, with the PFMA and the National Treasury requirements, tender processes are actually not adhered to. So just your opinion on that. Now, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our health facilities, and the fact that, these facilities need to reach certain compliance requirements under the NHI, we know that in the present circumstances, many healthcare facilities will not be able to function under the NHI. Do you feel that this will further hamper service delivery to healthcare to our country? Also the fact that the health ombudsman can't manage to oversee and ensure compliance. You have stated, in your presentation that, the Office of the Health Standards needs to also strengthen, itself. But how are they actually going to manage to ensure compliance under the NHI if they can't manage it right now? Now, we also know that at least 104 billion rand in medical negligence claims we have, existing right now. In your opinion, won't this be even worse under the NHI? And my last question, what is your opinion regarding the fact that so many interns and community service doctors and nurses are not placed timelessly? Also the fact that, many students go overseas to study medicine simply because there's no opportunity for study in this country, and the delay in the HBCSA in issuing of registration certificates after exams, that's delaying their placements and employment. we know you have touched on the Nelson Mandela Federal Castro program, and where students have come into universities, for the 18 months. But there's lots and lots of monies, being spent on that program. Would you recommend that? I know you highlighted in your presentation the issues of training, and more must be put into the bill, with regard to the establishment of maybe more universities of training with regard to healthcare workers, etc. Do you recommend that funds should be rather allocated within and in the country rather than outside? Thank you, Chair.
Thank you very much, Chairperson. Good morning, colleagues. Good morning to the deans. Let me welcome the presentation from the deans. I've just got two questions. My first question, Prof, you have made an argument that there is no mention of the National Health Laboratory Services in the bill. Did you miss paragraph 6.8 in the white paper, which provides details with regard to improving the efficiency of national health laboratory services in preparation for the NHI implementation? Did you also miss section 57, 4G3, which makes specific reference to the National Health Laboratory Services? Then my second question, Honorable Chairperson, the Dean have also raised concerns about decentralized purchasing, creating financial and administrative risk. What is the proposal of the Deans in this regard? Would you support centralized purchasing of personal healthcare services by the National Health Insurance Fund? Thank you very much, Chairperson.
Thank you very much, Chairperson, for the opportunity. Let me also welcome the presentation from Deans. I've got a few questions that I want to ask. My first question, you are worried that the bill does not locate the National Health Insurance Fund in the broader public health care delivery system. Are you recommending that a level of detail should be included in the bill over and above what is already in the bill, in the NHI policy document? My second question, my apology, Chair. My second question, Chairperson, you have raised concerns that there should be a separation of purchaser from the payer as contained in clause 2A of the bill. Can you please clarify further what you mean by this proposal in the context of the purchaser provider split? My other question, Chairperson, I think it's the last one. Have you aligned your suggestion to have a full new chapter on the role of the universities, which include training and quality of health service? Can you clarify how you propose this to be done? Do you want to have a chapter that deals with funding of universities and the training of health professionals? Thank you, Chairperson.
Honorable Munya.
To prepare my notes and other questions. My first question, Honorable Chair, is as follows. Maybe greetings to the esteemed professors and deans of one of the top universities in the Republic, medical universities. Are you concerned about the National Health Insurance Bill, that it provides an inadequate framework for the infrastructure and capacity or capability needed to achieve the desired outcome of universal health coverage? That is the first one. But then you have requested that NHI bill needs to locate National Health Insurance Fund in the context of the two-tiered national health systems with reference to the private health sector. Are you asking that the bill should redo the details contextual analysis presented in the white paper and the green paper? Is it your understanding that the NHI fund should maintain the inequality that is maintained in the two-tier health systems? It is the purpose of the bill, not the end to this apartheid-generated inequality? You have raised concern about concern that seems to be saying that the NHI fund bill, and not the NHI bill. Have you looked at clause 2 of the bill regarding to the purpose of the act being to establish and maintain the NHI fund? Would you agree that the NHI policy has outlined the critical health systems issues that will ensure successful realization of the mandate of the NHI fund? I think we owe it to the Dean to agree. I mean, I'm saying that maybe the Dean must clarify whether they agree with the current status quo of the two-tier system that really continue to put profit before the people. Because as you know, I'm sure the bill, as esteemed professors, the deans as esteemed professor, they will know that the current private medical aid, they receive 8% to the GDP, accounting over 400 billion, if not in no time will reach trillions. And that serves only 16% of the population. 84% of the population is not served with that money. Is that the view of the Dean that we should really maintain the status quo? It is very much important to understand that, Honorable Chair. I want to also ask Dean Risenga whether he agrees with the President Cyril Ramaphosa statement when he said, open quote, NHI is fundamentally about social justice. NHI will ensure that all our people, whether they are black or white, rich or poor, will be able to access a comprehensive range of healthcare services, close quote. I'm raising this because I heard the Dean talk about something like these issues. I want to further ask, does the Deans agree with the white paper, which notes, open quote, NHI represent a substantial policy shift that will necessitate massive reorganization of the current healthcare system to address structural challenges that exist in both the private and the public healthcare, private and public sectors. It reflects the kind of society we wish to live in, one based on the values of justice, fairness, and solidarity, social solidarity. Implementation of the NHI is consistent with the global vision that healthcare should be a social investment, not a private investment that put profit before the people. What is their view? Does the Deans agrees with the NHI, with the with also the white paper that says the implementation of NHI is underpinned by Vision 2030. Let me further ask this question. Do you also agree with the National Development Plan, Vision 2030, that envisages that by 2030, everyone must have access to an equal standard of care, regardless of their income, and a common fund should be established to enable equitable access to healthcare, regardless whether the people can afford and how frequently they need to use such a service? If the esteemed professors and the deans could please try to answer my question without fail, I'll appreciate. Thank you, Honorable Chair.
Chair, can I ask to start some responses now? I'm just mindful that we've only got 15 minutes and there's substantial questions that have been raised.
Yes, I do realize that, but it is not our practice, Professor. So we'll try and get through the next questions, and I will allow you a couple of more minutes so that you're able to answer those questions. Thank you. Honorable Tembakwayo.
Thank you, Chairperson, and appreciations to the information that was presented today. My first question is based on the context medical interns as he presented it to us, specifically on the 2021. And just to say to Professor, we engage on matters of medical interns and specialists upon receipt of the problems as they are experienced by those concerned. With this, I mean, sometimes we only get a complaint from the qualified doctors who are not employed, and we engage with the National Department of Health so that we get those qualified doctors to get employment. And the second one, we usually get complaints from the interns who are not paid by some hospitals, especially in Gauteng province, with reference to medical orthotics and prosthetics, specifically in hospitals like Dr. Mkari and Tambo Memorial Hospitals, who do not pay them any stipends. The only time when they get a stipend is when we engage and fight for them to get the stipend. But unfortunately, they do it only when we fight for them. The following year, they continue with non-payment of the interns. And I just would like to ask, because they come from the 10 universities that are part of this committee, what would your intervention be in this regard? Meaning, after they have qualified, do you, in actual fact, revisit the fact that they are employed or unemployed? So yeah, that is the first question. And the second question, where would locating of academia fit in the NHI bill as it is now? Please specify the section in NHI where it would fit. The same applies to the addressing of the social and economic determinants of health to promote health and disease prevention through intersectoral collaboration and strengthening non-personal health care. The following question, you mentioned that there's a shift of 2 documents. What would be the benefit of the reclaiming of the earlier document, since the move to the second document was necessitated by the public comments received? And the last one, you made a comment on the language, to say the language should be clear and more inclusive in the document. But I need some clarifications with examples from the bill. how exclusive, how certain sections were excluded in the NHI bill that would make it an inclusive and more clearer document, according to you, meaning inclusive aspects which are left out in the document. Thank you, Shane.
Honorable Siwela. Honorable Siwela. We'll go on to Honorable Albert.
Thank you, Honorable Chair. Welcome, Professor, for your presentation. I just have one question. The presenter has made comments which appear to suggest the Committee on Medical Deans is against the accreditation of service providers and the NHI. May I get some clarity on the presenter's inputs, particularly as they related to comments made about sections of the bill which cover healthcare services coverage? Thank you.
Is Honorable Siwela back? Thank you very much. I think those are all the members who are going to ask questions apart from myself. And I am sorry that I couldn't have your answer in between Professor Green Thompson, because it's not a normal practice. Yes, Honorable Tembekwayo.
It's not Honorable Dr. Tembekwayo. It's Honorable Gela.
Honorable Gela, yes.
Honorable Swela. She's having a problem. He's requesting that if he can be unmuted by the host.
Host, can you please unmute Honorable Siwela? You can speak as soon as you're unmuted, Honorable Siwela. Honorable Siwela, I would have to move on if we're not able to hear you. Let me ask my questions, and my questions relate to
Chair.
Yes, Honorable Gela.
Honorable Swela is requesting that if you can cover his questions. He sent the questions to you. If you can also ask his questions.
Yes, I will do that. Thank you very much, Honorable Gela. Let me then ask the question of Honorable Siwela first. And he speaks to the proposal that foreign students in South Africa must not be expected to purchase private medical aid or insurance. Are you saying that they must be allowed free access to healthcare benefits covered under the NHI or by the NHI? And can you clarify what the international best practice are in this regard? That's a question from Honorable Siwela. From myself, I want to speak to your to the fact that the NHI policy document makes a reference to the National Quality Standards for Health framework, which is based on 7 domains and 6 national core standards. Just to ensure that you're aware that the infrastructure is included in those domains. And secondly, that the question is whether you're familiar with the National Quality Improvement Plan. And in your view, does this plan not adequately address infrastructure requirements? And the memorandum of objectives also mentions the quality improvement plan, that you maybe miss that information. And In the comments made about the registration and documentation of users and beneficiaries under the NHI, the medical deans appear to condone and advocate for South African residents to remain undocumented. Is there any reason for this approach? And most importantly, how will health records of these undocumented individuals be tracked and traced over time? If what the presenters' proposals are considered in the bill. So if it's considered, how will these undocumented individuals be tracked and traced over time? And then based on the comments on the preamble, the South African Committee of Medical Deans have made proposals for the bill to be amended in line with the current segregations of the public and private sector. May I get some clarity why your emphasis is not based on equitable access to healthcare to the South African population, but rather it focuses on maintaining the status quo, which is based on public versus private sectors as we currently understand it. And then you also spoke about oral health and identified oral health services of refugees and foreign nationals as the key point. Is there any specific reason why this category of persons and the health needs have been elevated? And why have you also singled out only the inspection of oral health by the Office of Health Standards Compliance? And then your reservations with regards to the power of the funds. Do you have any recommendations to remedy what you regard as a problem in the bill? And put differently, what amendments do you believe should be made under Section 11 of the bill? I noticed there is a hand of Honorable Munyai has been raised. So before I'm going to hand over to you, Professor, I'm going to take the hand of Honorable Munyai.
I'm covered fully. Sorry, Honorable Chair, and thanks.
Thank you very much. At this time, let me also welcome our Deputy Minister, Dr. Sibongiseni Gloma. I see he's on the platform, as well as the Parliamentary Liaison Officer of the Minister, Mr. Johannes Hatla. You're also welcome, and I know you've been on the platform for a little while. I'm handing it back to you, Professor Green-Thompson, and I will give you some extra time, and whatever you would not be able to answer, you're very welcome to also give us a written reply to the other questions. Thank you.
So, Chair, I mean, a number of questions I think would benefit from a written reply so that we can engage more collectively with colleagues. I'm going to ask Professor Rizenga Chauke to respond, particularly since somebody asked him a particular question. And then I'm going to ask Dr. Kieran Begg to deal with some of the technical questions. I see Professor Glover is still here. And then I will pick up whatever questions colleagues have left out. I don't know if colleagues are happy with that. But Professor Chauke?
Thanks, Prof. Green-Thompson, and thank you, Chair. When the world met in Russia in 1978, the Declaration of Alma-Ata was signed, and the world said, by the year 2000, there must be health for all. But 1978 was a far cry from when NHS was established in England in 1948 after the World War II. And the formation of the national health system then described a great and novel undertaking when NHS was established. We will realize that NHS was established when there was nothing to base the establishment of that system on. And I'm trying to answer the question about whether we should wait for infrastructure or, and things like that to be established. And our taking is there will never be the correct time to start NHI, and it has to be done now, and now is now. Yes, I do subscribe to the undertaking that NHI is about social justice. I agree fully with what the President says concerned. And it is important to realize that we will never have a perfect system, and we will never have a correct time to establish NHI until we establish it as and when we speak right away. Yes, we don't believe in a two-tier system of health in the country, and we believe that a one-tier system should work without really compromising the other. But it's important to strengthen the public health system. And we also believe that the medical training institutions and tertiary and quaternary hospitals should be sitting in the national Department of Health rather than in the provinces, because we think that will be the better control will be flow from there rather than from the provinces. Basically, because we know that there are a few other things that happen that really compromise the health system as far as them being run by provinces is concerned. So in short, and I believe that there are many questions, I think we can then, through Prof. Green-Thompson, have a written reply to some of the questions raised here. But at the end of it all, and with in a summary of the analysis, it is important to start it now without really waiting for a perfect system to be established before it will be started. Thank you very much, Chair, and thank you, Prof. Green-Thompson.
Thank you, Prof. Chalke. I'm going to ask Dr. Beg to answer some of the technical questions, and then I will probably, colleagues, just because of where we are on time, take the remainder of the questions for written reply, and we'll give you a sense of what so you would need to give us a sense of the timeframes for those responses. Dr. Beg?
Thank you very much, colleagues, for some very insightful questions. And so I think that Prof. Rusenga has just indicated very clearly that we certainly are supportive of a single healthcare system and the undoing of the inequitable two-tier health system that we sit with at the moment. Colleagues, I think that a number of questions related to the white paper, and we're certainly particularly in support of the white paper, but what we were asked to do today was to comment on the NHI bill. And certainly I think what we are concerned about is the disconnect in some respects between the white paper and the NHI bill. To some extent, perhaps the NHI bill would be better articulated as an NHI fund bill, because that is more what it represents, and then perhaps there needs to be additional legislation that puts effect to some of the gaps that are then in the bill versus the white paper. So we're certainly in great support of the principles within the white paper, and with some additions and modifications as has been submitted previously. But in terms of the NHI bill, it is a paring down of the white paper, which has indicated some of our concerns today. So let me take some of the specific questions that were asked today. In terms of the tiers of governance and therefore the equity, we particularly strongly in support of equal access and equitable resources and equity in terms of treatment of all in South Africa. I think the comment about the preparation is real, and I think that the pilot projects have been problematic and have not given the results that we would all have expected, and they certainly have not been written up in an evidence-based way that we would really have liked to have seen the evidence. The pilot projects have also predominantly focused on district healthcare systems, and to a very small extent the contracting of private providers, but only in terms of individual practitioners. And so perhaps some of the piloting should be extended into hospital-based spaces and other areas that are not covered currently in the pilot projects, which are at district-based level. In terms of the purchaser and funder, so the NHI fund, I think that we clearly indicated in the response that we provided that we certainly wish to see the purchaser and funding mechanisms separated so that we have good governance aspects there. The single purchaser, I think we're concerned with, particularly given some of the challenges that we've seen in our country recently. And so we would advocate for some sense of decentralization. There is obviously benefit in terms of efficiencies with purchasing that can be negotiated at a global scale, but we're certainly concerned about that all being tied up in a single purchaser model, which currently would also not fit with the current governance models of the fiscal federalism in provincial entities. So in terms of quality, I think we are completely cognizant of what sits both in the NHA, the National Health Bill, the National Health Act, and the modifications, the amendments for the Office for Health Standards Compliance, as well as what sits in the white paper. The tie-in and coherence towards to the NHI bill is not there. Hence, perhaps the suggestion that the NHI bill as it currently stands should rather be named an NHI fund bill, and then other aspects around service provision and quality control should then perhaps be located in an additional piece of legislation going forward. So we are concerned about the capacity, and certainly it would need to be extended. It is predominantly a quality assurance-based mechanism and not a quality improvement mechanism. So thank you very much, Chair, for the comment. Certainly that many of us have been involved with contributing to the national government in terms of the Lancet Commission on High Quality Health Systems, as well as the National Quality Improvement Plan. Many of us have participated in and contributed to that formation. And so once again, we have good policies and good principles in South Africa, just not necessarily the good delivery. And I think that was what the Honourable Member Ishmael was referring to. Medical negligence is a particular challenge and will continue to be, but obviously as we improve quality of services, so that should deteriorate. I think that perhaps I'm going to move on to the next aspects, because I think that Professor Rusenga did mention a couple of the other items, but I'll comment on the particular aspects around that affects us directly around the training of health professionals. It is of concern that interns, community service, and nurses are not placed. The delays appear to be more around funding of those posts, so particularly in austerity times, like we are at this point in time, post-pandemic, or within the endemic space, is that those posts are contract posts, and they're the easiest to curtail from provincial expenditure basis. And there isn't a coherence between the national placement of those particular professionals and the funding of those posts at provincial level. And so when austerity measures are faced, it appears that provinces then cut posts, and the number of interns, community service health professionals are then not able to be placed. We haven't seen as significant delays sitting at the HPCSA issues. In terms of where our health professionals should be trained, we certainly believe that we should be able to train all the health professionals that we need, but we certainly need a significant ramping up of the numbers of health professionals that we can train within the country. But of course, the con is that if we aren't able to place those that we train, then it is a very expensive exercise to train health professionals that they're unable to be placed. So it does need a lot more coherence between the HEIs and the national department and provincial departments of health, as well as a very long lead time in order to get those health professionals qualified. We do have a challenge at the moment with a number of people who are unable to get into HEIs training overseas, and then wanting to, in unaccredited spaces, wanting to then return into the country. So that is a particular challenge. We'd certainly want to work together with government to be able to train within our country. In terms of continuing on the NMFC program, what we've seen around the NMFC program is that students recruited from rural areas tend to return to rural areas, and certainly from a SACMD point of view, and the deans and faculties of health sciences, we're certainly looking at those kind of elements so that we can ensure placement within rural environments. I think I'm going to pause at that moment and hand back to Professor Lionel Green-Thompson.
Thanks, Dr. Begg, and thanks, colleagues, again for your questions. I mean, there's some things that very simply in the way that colleagues have asked the questions, like immigration, I don't think one can predict any of that. In terms of the immigration of health workers, I don't think one can predict how that will be affected by NHI. I do want to reiterate some of the things that Professor Chowke said, that in fact, the deans remain committed to equitable access. And I didn't think, and I made the point of both, and I don't think we were saying that private healthcare must not be managed in the process of NHI. I think it's an important part of the process that we need to engage with. Colleagues, I'm just very mindful of the time now, and I wondered, Chair, if I could ask the Secretariat to document the questions, and we can give you a response written quite quickly. The question that Honourable Tembagwayo asked about, where do we insert the ideas? I think we had spoken about an additional chapter relating to higher education institutions. The question of the wording that we felt could be changed for more inclusivity is written in our written document. But yeah, I think, Chair, if I can get from the Secretariat a written version of these of the questions, we can engage with them in more detail and involve more colleagues in the response. But I really want to leave the committee with the notion that there is support for a move towards a national health for universal coverage, and recognize the NHI to be one of the contributions in this regard, an important contribution to achieving equitable access to healthcare. It's no longer acceptable that people have health catastrophes at the lower end of the market. Thanks, Chair.
Thank you very much to yourself and your team, Professor Green-Thompson. The one point I had not raised, but is also to commend the universities for training more medical students. I remember the time when it was my task to go to the deans and discuss with them the increased intake, possible intake of medical students. That was back in 2011. And I see we've come a long way, us now having had 1,889 doctors being trained locally. And the additional number coming from other programs like the Nelson Mandela Fidel Castro program, etc. But also commendable that we've increased the number of medical specialists and subspecialists being trained. And we know that as we're going towards the national health insurance / universal health coverage, we will need an increased number of training of our medical doctors and especially our specialists. And we also do know that there are constraints with regards to those. It'd be nice to also hear from you when you do those written replies, to maybe also speak on those topics and what your views are as to how we will be able to do that in preparation for the human resources for health in terms of the NHI. But we look forward to the rest of your replies. It's really a pity that we cannot take all of those orally from you now, but we are very interested in hearing more from you. I'm going to give you a moment just to maybe make a final comment, and then we will move on to our next presentation.
Thanks, Chair. I mean, I suppose the one thing that I do want to raise, and I'm trying to work out which honourable member raised it because I lost track of the names. The question of responding to doctors who are not being paid, and the honourable member saying that this committee acts when they receive a complaint. I want to ask, because we've tried to preempt these situations, both of the allocation of staff, of interns, as well as this issue around, and locally people have engaged. But I wonder if as a request from myself, and I haven't canvassed it with the committee, that your portfolio committee looks at ways in which we can anticipate these, because there's some provinces in which there are recurrent problems in this regard. And that would be important. So, Chair, as a concluding remark, I really just want to say thank you for this opportunity. I think that the members' questions have been insightful, some more difficult than others in terms of a response, but I want to recognize that we come in a collaborative spirit, and in our response to the questions, we continue to be collaborators in trying to craft a better health system and a space in which our people can enjoy good health. Thank you.
Thank you very much again, and you're very welcome to write to our committee secretary. But she's also noting what we are saying now, so there can just be a communication channel between yourselves, so that you'll be able to see those written comments from you. Thank you once again for coming. You're welcome to stay on the platform. You're welcome to also leave in your busy schedule, but we are having a presentation now from the OWL, and the OWL is led by Mr. Zola Sapeta. Mr. Sapeta, if you can please introduce yourself and introduce the rest of your team, and very welcome to this portfolio committee on the NHI Bill public hearings. Please continue with your presentation. Thank you.
Good morning, Chair and the Portfolio Committee. My name is Tengo Tengela, the Parliamentary Officer of NEHAU. I'll be doing the introduction of NEHAU delegation. Our delegation chair is led by our General Secretary, as you have mentioned, Comrade Zola Sapeta. He is accompanied by the NEHAU Policy Development Unit Head, Mr. Comrade Sydney Hara, and Slindile Mbele, who is our researcher, and the head of Secretariat, Skumbuzo Mkonda. Our presentation chair will follow the following sequence. The General Secretary will do preliminary comments. He will then be followed by Slindile, who would deliver our presentation. Thank you very much, Chair. Let me hand over to our General Secretary, Comrade Zola. Over to you, yes.
Can the GS hear us?
Thank you very much, Comrade Tengo, for introducing us as a delegation of NEHAU in this engagement we have today. And good morning to everyone present in this engagement. Chairperson, pardon me, I have a technical problem with my camera, and that's why you might not see my picture, but I have tried my best, and hopefully you will hear me. Chairperson, as an organization that was born in the struggles of the health workers, which united the clinicians and the general staff alike, who were all inspired by the ideals of a universal health coverage as expressed in the ANC's African claims and the Freedom Charter of the Alliance. We are proud that this national insurance bill is finally on the threshold of being passed by this 6th democratic parliament. With regard to the national health insurance, understood as a health financing system that pools funds to provide access to quality health service for all South Africans based on their health needs
and irrespective of their socio-economic status. As NEHAW, we pride ourselves as a pioneer, having spearheaded the campaign since our adoption of the National Health Insurance at our Congress in 1997. Inspired by the fact that many countries achieved universal health coverage immediately after the Second World War, when their economies and the health system were still devastated by the war. NEHAW worked with various organizations in developing proposals for the NHI in total conviction that it is not only possible, but also necessary in South Africa. Our campaign included joint working with our Canadian friends, the Canadian Union of Public Employees, in generating some of the earliest research papers on NHI model under the democratic order. We are also proud that we successfully campaigned against the introduction of the social health insurance in the late 90s and 2000s, even up to the end of the work of the Ministerial Task Team on Social Health Insurance, which disappeared with the third democratic dispensation. This paved the way for the introduction of the Green Paper on NHI in 2011, and subsequently for the publication of the NHI White Paper in 2017, in which we vigorously participated throughout in making our submissions. And finally, in 2019, we actively participated in the public hearing that were held in provinces on this NHI bill. So, Chair, let there be no doubt that we are here to express our unwavering and resolute support for the NHI bill, which would enable our country to take a giant step forward in complying with the supreme law of the land, as captured in Section 27 of our Constitution, which mandates government to take progressive steps to fulfill the citizenship rights, in this regard, access to health for our people. With these provisions, in terms of Section 27, our Constitution is very clear that health is a right, not a commodity. No, it is a privilege. Of course, we know that there are those who have never struggled for this Constitution, who actually did everything to oppose the democratic struggles for this Constitution, but who today pretend to be its champions and who are going to abuse our courts in trying to block this legislation. Our message to them is clear, Chairperson, that on a yearly basis, the state provides around 60 billion in tax subsidies in favor of the private healthcare sector. This includes the unconstitutional tax expenditure subsidies enjoyed by members of the medical aid scheme by the Treasury. Any attempt to delay the implementation of this bill shall be met with our own action, not only in terms of mass protest, but also legal action, to ensure that the overwhelming majority of our people do not continue to be discriminated against, as they are deprived of any subsidy when they seek healthcare from private doctors in townships and rural areas. We shall then see if the profiteering private healthcare industry would survive even for a year without these tax subsidies. It is now official. It is officially documented by the Health Market Inquiry of the Competition Commission in its 2019 report that the private healthcare system is systematically flawed. Actually, it is scavenging on the vulnerable and the sick. We demand that the National Department of Health must urgently respond to our call, which we made during our peak heads on the 18th October 2019. We demand to see a plan of action from the department, outlining how it is responding to the recommendation of the Competition Commission, especially with regard to the need for a regulatory intervention to prevent price collusion and profiteering amongst the three monopoly hospital groups, as well as over-servicing of patients by practitioners, especially the specialists. At this point, Chairperson, I would invite Comrade Slumile Mbele to present our technical presentations, and then we will come back to engage with the questions that were asked. Thank you very much.
Thank you, GS. Thank you, Chair. I'm going to continue from where the General Secretary has led the foundation. He has already tackled the introduction of our presentation, which explains how the injustices of the past continue to follow the majority of South Africans and how we need to stand up as a country to actually address these injustices and allow access to healthcare to all. Comrade Chair, my presentation will look at the issue of funding. We'll touch a bit on the issue of funding, then we'll talk to the decisions that the National Treasury or government have put forward that we feel will continue to delay the implementation of the NHI. We'll then talk to the private sector and how it has been said to be the best and provides the best healthcare services. And we'll also talk to the argument that why can't we leave the private sector as it is and focus on the challenges that are faced, that the public sector faces, instead of addressing both issues of the private sector and the public sector. Okay, Chair. Firstly, NEHAW supports the NHI, and when it comes to the funding, Section 49 of the bill, it states the chief's income that will be used in funding for the NHI. That includes the contribution from the member, the contribution by the employer, and also income tax and other forms of funding like your CODIA. In our presentation, we want to touch more on the tax expenditure subsidy for medical aid scheme. Government subsidizes medical aid scheme holders through what we call a tax rebate. This means that people with medical aids, they get incentivized for purchasing medical aid. And the higher or the more expensive the product that the person has within that medical aid, the greater the subsidy. As NEHAW, we believe that government should completely end the tax rebate, and it should form part of other funding for the implementation of the NHI. The fund needs to be redirected towards the implementation of the NHI. On the next slide, Chair, the table gives us a picture of how the rebate has been increasing from 2013 to 2022. In the same breath, Chair, we've been experiencing a decrease towards the budget, the health budget, as a result of austerity measures that have been imposed by government. This clearly demonstrates the unconstitutionality of the tax system, which is protected by the finance policies that promote financial well-being of the affluent at the expense of distributing a universal public good to all citizens. In the 2021-22 budget review, Chair, we've seen this decline, and it is also forecasted that we're still going to experience a decline in expenditure for health. In the 2020 and 2021, the budget was sitting as 247 billion and is expected to decline to 245 billion in 2023. What we want to put forward, Chair, is that the austerity measures that government or National Treasury impose on the public health sector have great impact on the functioning of the sector. The main factor that has been affected by austerity measures, it is the increase in the shortage of healthcare workers. And this was more evident amidst COVID-19. Austerity measures, Chair, and the way they increase the shortage of human resource, they have contributed to the public sector's inability to provide healthcare services effectively and efficiently, which is critical for an attainment of quality healthcare. Again, Chair, we want to put forward that these austerity measures, as imposed by our National Treasury, they undermine the public sector's ability to comply with the national core standards as put forward by the National Health in trying to achieve improved access to quality healthcare. Again, these austerity measures, they undermine the public healthcare ability, the human resource for health strategy that talks to adequate distribution of health providers or healthcare workers between the private sector, the public sector, between urban areas and rural areas. And Chair, the austerity measures again continue to affect now the same healthcare workers that are already part of the system. These workers have been subjected to precarious conditions ranging from receiving low incomes, government undermining collective bargaining agreements, and working under poor conditions, which were even more aggravated by the coronavirus pandemic. As things stand, Chair, we have temporary healthcare workers that were employed to assist with combating COVID-19 that are now potentially faced with unemployment, provided that their contracts are not renewed and or converted to being permanent. Chair, this equally becomes a strain or a constraint to the effective implementation of the NHI. While we're still on the issue of funding, Chair, reactionary interest groups that are opposed to the NHI, they argue that its implementation will be a burden to the already strained fiscals. As Nehal will say, this is just a tactic aims at maintaining the apartheid structural inequalities, privileges, and injustices that are still inherent in the healthcare system. The same groups, Chair, have failed to provide alternatives that will meet the fulfillment of the requirements of Section 27 of the Constitution. It was really sad yesterday to hear from AfriForum saying that another alternative to the NHI it's for us to expand the medical aid market so that we create competition in the market, and then that will drive down prices. Then everyone can afford to have a medical aid and have access to quality healthcare. This just shows that there are people who still don't understand that we have people in South Africa that still go to bed without food. We still have people that can't afford a loaf of bread. We have people with zero income. Those people will never be able to afford any medical aid, no matter how much that medical aid can cost, because they've never had any access to any income. So we believe that the NHI is the only policy towards achieving universal health coverage, whether you have access to money or not. So to go back, Chair, on National Treasury, despite the commitment that government has made to the development plan, the NDP, which calls for universal healthcare through the NHI, and despite the NHI bill being passed, and the National Treasury has listed the NHI as a spending risk in terms of the medium-term risk framework. Yet, Chair, as my General Secretary has alluded, National Treasury is willing to forgo up to 60 billion, or which was 57 billion of tax subsidies for medical aid scheme members. Chair, as Nehal, we condemn this, and we say that since National Treasury has made this decision to cut spending on health, we therefore call for the end of medical aid scheme tax rebate and have the money or the funds earmarked towards the implementation of the NHI. The main reason, again, Chair, why we are against the tax rebate is that we believe that if an individual decides to purchase a medical aid insurance, then they make that decision because they can afford it. And so they shouldn't be provided with an incentive in the form of a tax rebate. Again, Chair, we have people in the townships, rural areas with no medical aid, have never had access to medical aid, have been using out of pocket when visiting a doctor. And there is no incentive that is afforded to them. Instead, they have to pay VAT. This is just another clear picture of the inequalities that the underprivileged are subjected to. Chair, I'm going to now talk to the structural reorganization that is envisaged in the bill, which pertains to the NHI fund that is publicly administered. I will talk more to that when I talk to the private sector. Then also pertaining to the future of role of provinces, tertiary institutions being provided with autonomous powers, and the creation of the contracting unit for primary health care, which is also shortly known as CAP. We support the restructuring and reorganization, but we want to put forward that any structural reorganization and reconfiguration of any organ of government should not deviate from the philosophy of providing a public good. Any structural change, Chair, should not in any way distract negatively on the terms and conditions of employment of the workers. Workers must remain part of the public service, and the organs of the state must remain within the state, including the CAP. I will talk to the NHI fund on when I go to the slide on the private sector and how we support it being the single purchaser of healthcare services. Then now, Chair, then I go through the private sector, which is assumed or known to have the best quality healthcare or provides the best quality healthcare. The same private healthcare sector in South Africa, it is characterized by high and rising cost of healthcare and medical aid schemes. High and rising cost of healthcare and medical aid schemes. This has been proven in the Competition Commission on Healthcare Market Inquiry. Again, during the health market inquiry, WHO made an indication that our private healthcare in South Africa, the prices are on par with the prices of countries with higher GDP levels. These include the United Kingdom, Germany, and France. Our private healthcare is dominated by the oligopolies and also known as the big three providers. That's Netcare, Mediclinic, Life, and Life. These oligopolies, Chair, have created barriers to entry, thus preventing competition in the market by using tactics such as price fixing. Again, the World Health Organization continues to say that South Africa spends 41.8% of total health expenditure on private voluntary health insurance, which is more than any OECD country, while only caters to the 17% of the population. And again, this 17% of the population, some of it relies on the public health sector. I'll talk more on that. So it's only those with high income that can afford medical insurance in South Africa. And the same people that have medical insurance have been subjected to high rising pay out of pocket for their healthcare services in certain circumstances where it's either they've run out of funds from their medical aids or the medical aid doesn't cover those health services that that person requires at that point. Chair, according to the Council for Medical Aid Scheme, medical scheme members in 2014 paid out of pocket of 24 billion. That was in 2014. And this went up in 2015 to 27.2 billion. This is a lot of money that people are still paying from their own pockets while they have medical aids. Chair, I want to share just a short story of how the out-of-pocket payments have become a strain or a financial hardship to the people with medical aids. There's a popular doctor on social media that has been known for her good work in assisting her patients or the people that have always required her services. So she became popular on social media for the good work that she has been doing.
Consulted and take a decision as members or as a constitutional that sees once in 3 months.
Can you please mute whoever is interrupting our meeting?
Thank you, Chair. I'll continue. The doctor was then admitted for, she contracted COVID-19 and was admitted after a week of being sick. She had to spend close to 6 weeks, which is 2 months, in hospital. In that 2 months, she then had difficulties in breathing, which required her to be under ventilation. Being under ventilation for this long period then put a strain on the family financially, as they had to pay for the services from their own pockets now. They then decided they will reach out to the public because the bill was getting too much and they couldn't afford it. They reached out to the public, as the doctor was very much known on the public platforms that we have. They then did a crowd campaign funding for her, and the goal was to reach 2 million for health services that she was getting from the hospital that she was admitted to. I don't know, Chair, how one can have a bill come to 2 million, but it does happen in South Africa. The public was able to raise up to 1 million for her. Many companies came through and donated money towards her medical bills. Unfortunately, she didn't make it, and she passed away. This is just one of many stories that people are faced with the high cost of our private healthcare. This is what the WHO talks about when it says access to healthcare should not impose any financial hardship to the person. And with this increase in out-of-pocket contribution from medical aid members, this is the hardship that the WHO talks about. Chair, this just gives a clear picture that private healthcare in South Africa is unaffordable and has turned healthcare services into a commodity that is only enjoyed by only those who can afford it. And by only those who can afford it, one can assume that it will be the 10% that owns 93% of our wealth in South Africa. In addressing the cost, the bill indicates that the NHI fund will be the only purchaser of health services. Chair, this will then exert powers or give powers to the fund to be able to negotiate and determine better prices for medication and healthcare services. Obviously, Chair, we have groups that are against this, Discovery being one of them, that is against the single purchaser payer model, because they know it will kill the fee-for-service reimbursement method that is currently predominant, that is predominantly used in the private sector. Chair, the fee-for-service reimbursement method, it creates an incentive for providers to increase volume or cost of care that they deliver through additional tests, procedures, inpatient stays, and outpatient visits. This was also proven by the health market inquiry. And it stated that our private healthcare is characterized by high admission rates. Why is that? Because that's how they are able to generate more income through longer admissions. So we understand fully, we are not surprised that Discovery is against another reimbursement method that seeks to put value for service forward. Chair, again, for a country with such high unemployment rate, sitting at 34.9%, high levels of poverty and income inequality, we cannot afford to have high cost of healthcare. In actual fact, it cannot afford to commodify its healthcare. As NEHAW, we believe that the NHI will provide the country with the health system that is for everyone and achieve the health goals embodied in the NDP, which significantly reduce the burden of disease, ensure that we raise the life expectancy of South Africans at least to 70 years, the generation of under 20s largely free of HIV, and achieve an infant mortality rate of less than 20 deaths per 1,000 lives beds, including an under 5 mortality rate of less than 30%. And with the NHI, we believe we can achieve these goals. And then we go and talk to the argument, Chair, that why can't we leave the private sector and focus on the collapsing public health sector? What we want to say, Chair, is that you cannot separate the two. The private sector events, they adversely affect the public sector, and hence it is not possible to separate the two and solve their problems individually. I'll just give a few pointers on how the two are related and can't be separated. One, the private sector employs medical practitioners who were originally trained at the public expense. As a result, the public sector then loses its investment in training of health professionals. This is evidenced with the doctors from our public medical schools. Two, we have GEMS, which is a medical aid for public workers. The same medical aid that they use to purchase the services in the private sector, and they get subsidized for it. And again, Chair, there are healthcare services that the private healthcare does not offer. And when they don't offer these services, they then refer the patients to the public sector. And when they do that, the medical aids do not pay for those services the same way they would have paid should the private sector offer those services. Obviously, the medical aids, they won't pay for the services because the public sector, it is free and it's not meant to generate profit. And again, Chair, the same medical aid, the same medical scheme holders, when they exhaust their funds before the year end, they have no other choice but to go and seek the help of the public health sector. So, Chair, we say the public and private sector, they are part of a single system. When there is an imbalance that favors the private sector, it necessarily has a negative impact on the public sector. And then as I conclude, Chair, we want to say NEHAW supports the implementation of the NHI as it seeks to transform historical injustices and structural inequalities caused by the former apartheid state. The current state of the public health was transmitted to us from the past, hence we are duty bound to changing these conditions in a democratic society. Again, Chair, in order to strive to improve quality and equitable access to healthcare, the NHR will have to alter health staffing requirements. To achieve increased health-seeking behavior implies increased need for all cadres of health care workers, particularly our specialists and general practitioners, who are very much underrepresented in the public sector. If the South African health system is to overcome the challenges it is presently faced with, we need strengthened political support so that financing can be restructured and the roles of both the public and the private sector can be redefined. I thank you, Chair. Amanda.
Showing your face.
Thank you very much. Any other inputs from NAO? Any other members of NAO at this point in time?
No, Chair. We are ready to take questions. Thank you.
Thank you very much for your presentation and coming to present to us this morning. We note the content of your presentation. There are a number of members who want to raise some questions with you. I'm going to mention them in the order that they've raised their hands. It's Honorables Munyai, Ismail, Clark, Tembakwayo, Sukacha. Munyai, Ismail, Clark, Tembakwayo, Sukacha. Any other members who want to raise any questions, you can shout on this platform so I can add you to this list. No other members? Please continue, honorable members, with your questions.
Honorable Chair, and greetings to the Progressive Trade Union, NEHAW. Some say the most advanced union of the public sector. And I think, thank you very much indeed for your comprehensive, insightful inputs on the bill. which some of us, we got enlightened by something that we believe we don't know or we may not know. My question, therefore, to Nehao is as follows. In Nehao's comments regarding the need to appropriately ensure the distribution of health professionals across the health facilities, can they clarify or share some of their views how this could be done under the National Health Insurance? In the response, Nehao should take into account the fact that under the internship and community service placement program, the refusal of some graduate to go and work in rural areas it's one of other major contributor to the lack of placement of the most graduate in rural facilities, of which majority of them falls within the public sector, and they are and they are located mostly in rural areas. I would greatly appreciate Nehao's views regarding the possible solution for such issues under the NHI. Nehao also, this other question, Honorable Chair. Nehao also made a view that South Africa is leveled with massive unemployment and inequality, which that one I fully agree. And also they raise the issues of the massive budget cut in healthcare and other social services. I think I'm in content with that because I serve here in Parliament in the Portfolio Committee on Health. So I know that fact. But now, there also argues that there are critics, or rather the detractors, who are opposed to NHI. What is their view? What is the alternative that they provide, these detractors? What their views they express that things to undermine this transformation? Of course, something to note, Chairperson, Honorable Chair, is that Nehao argues that this is apartheid law that need a reform. For me, as a Democrat, and also respect the democratic breakthrough, if there's any other aspect of the legislation that seeks to segregate our people based on apartheid, which has been declared an enemy by the enemy of the people by the United Nations, therefore, I should not hesitate for advancement for that transformation. But of course, that should be based on the views, on the input of our people, or the presenters, amongst that being Nehao. I want them to reflect who are those detractors and what do they say. And I know some say it's okay, the precondition for NHI, solve first the issues of the infrastructure and public services, and so on. And yet they know the inequality that you presented. What is your view around those critics? What is the estimated period for Nehao that they think NHI could be progressively realized into law? Lastly, it's not in fact last, the issue of the current status quo, which the private medical aid schemes receive 8% to GDP, accounting over 400 billion, and save only 16% of our population of the few, yet 84% of the population are not served. What is the view of Nehao on this on this approach? Do they still support this status quo, or they want it to go like the silver bullet? Lastly, it's one of the last, I have many last, Honorable Chair. Does Nehao, and I'm sure I wouldn't have captured all the aspect quickly, but there's an aspect that they've raised. I think, do they agree that with President Ramaphosa that, open quote, NHI is fundamentally about social justice and will ensure that all our people, whether they are black or white, rich or poor, will be able to access the comprehensive range of healthcare services, close quote. If I would appreciate that view. What is the view of NEAO on the white paper? Open quote, NHI represents substantial policy shift that will necessitate massive reorganization of the current healthcare system to address the structural changes that exist. I'm sure they've raised some of those structural challenges in their presentation in both the private and public sectors. I'm raising this, Honorable Chair, that so that no private, no public sector should want to emerge as the holy. So the views of the presenter is critical on these issues. Just to conclude, do they agree on the values of justice, fairness, social solidarity as a way towards implementation of the universal health coverage? Because some will say we want universal health coverage, but this universal health coverage must be without NHI. What is the NHI? What is the NEHAO view on this regard? Thanks.
Good morning, Chair, and good morning to everyone. And thank you to NEHAO for your presentation. I have a variety of questions. My first question. Now we are, 27, 28 years into democracy. We've had a new dispensation in government for at least 27 to 28 years. Would you think that in this 27 or 28 years, our healthcare system could have been attended to or fixed, where, we have universal healthcare for the whole country? The reason I'm asking this is that we know the NHI bill that we're looking at right now is a funding model. We know that our healthcare system, for want of a better word, is in tatters. Now, we all look at NHI as a tool, as a means to provide quality healthcare to the country. But we also know that this NHI bill is actually a funding model. On the basis of that, I ask these questions. Your presentation mentions that you agree with the single purchaser and single buyer model. Now, what your submission does not take into consideration is the flaws in the implementation of our procurement laws. According to the PFMA and the National Treasury instruction to date, departments are meant to advertise tenders with details such as price, company name, award date, etc. In addition, the PFMA highlights that price is the first indicator that should be considered when awarding tenders. However, as we have clearly seen in the SIU report, tenders were awarded to companies that overcharged for products or services. Now, considering the flaws in implementing procurement rules and regulations, how do you actually foresee this as substantial and lowering of prices? How is the fund actually protected from ANC cadres seeking to fill their own pockets, as we have seen in the Digital Vibes scandal? What suggestions can you provide to protect the fund from political interference? My next question. Noting that NHI will be sourcing funds from taxes and the tax base in South Africa is relatively small. We all know that we have underprivileged. We all know that we have a major unemployment crisis in this country. Do you feel that the pool of taxes will be sufficient to carry the bill, since presently the private sector is in the forefront in assisting with health services to the country? My next question. Do you feel that while the private sector is complementing the private sector, the National Department of Health should concentrate on upgrading infrastructure? do you actually think that we will access quality healthcare services if we don't first ensure that we increase the amount of healthcare workers and upgrade health infrastructure? You know, we all know that we have a major issue with shortage of healthcare workers at all levels and in all provinces. And the main reply that we get from the departments are short of budget. Now we're already facing a shortage of budget crisis in this country. With the minimum tax base that we have, how is this NHI fund actually going to work? My next question. Don't you think that the freedom of choice is, infringed? Or what I'm trying to say here is, don't you think the freedom of choice is infringing the right of choice, whether to choose a medical aid or not, to the masses of this country? So frankly, I'm asking you, is the bill, constitutionally aligned? Now, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our health facilities, and the fact that health facilities need to reach certain compliance requirements under the NHI, we know primary healthcare at our clinics is core to most of our people in this country. Now, under the NHI, due to the fact that most of them, whether it be clinics or hospitals, will not meet NHI standards, don't you think that this will stifle or impact health service delivery to communities, which is really needed? My next question. Under the bill's current governance and organizational structure, do you recommend the private sector be included on the board to improve the accountability and legitimacy of the board? Do you recommend Parliament oversight to mitigate the threat of corruption? My next question. Do you feel that the bill will stifle innovation in the healthcare sector? And do you feel the access to top-up cover will actually assist in covering the extras? The extras like for chronic patients? I mean, won't we have more fatalities? Because by the time we have those referral letters, we may just lose, a lot of people before they can get efficient and sufficient healthcare. Now, we already know that of at least 104 billion rand in medical negligence claims currently. Don't you think that this will be even worse under the NHI? Thank you, Chair.
Honorable Clark.
Thank you, Chair. I've just got a few questions I would like to ask. One is, would you say that within the South African context, our infrastructure is equal to the benchmarking of other countries internationally in terms of NHI, where internationally it's been implemented? Two, what is your view in terms of the contributions of the private healthcare system to the economy of this country? And how would you resolve the jobs that will be lost within the private healthcare system if it no longer would exist within the marketplace? Three, I've just been reading this morning again where, for example, the Edenvale Hospital hasn't paid security officers, their cleaners, etc. for the past 3 months. Do you think this kind of practice under the NHI health system would be mitigated? Because we often hear of healthcare workers not being paid on time for months on end. Do you believe that the NHI would be able to mitigate this kind of practice that happens often throughout the country? And do you think that if VAT had to be increased, for example, to fund the NHI, how would that have an implication on the poor of the poorest, considering the high cost of living costs we have to contend with in this country at the moment? For example, food prices, interest rates that have just gone up again, in terms of fuel prices, transport that's gone up, electricity that they're now wanting to put up another 20%. I mean, if we had to put taxes up, and particularly there's a talk about increasing VAT, that is going to have a devastating consequences on the poor of the poor in our country. Thank you.
Honorable Tembakwayo.
Thank you, Chairperson, and thank you for the presentation. I've got only one question and a comment. And the question is based on the more temporal healthcare workers during the COVID-19 period to date, with reference to the 2,900 health workers in the Eastern Cape who have lost their jobs as we are speaking, and they are still making use of whatever revenue is available to help them get their jobs back. What is NEHAW's view on this issue and other related issues in other provinces, and which applaudable intervention can you provide? And a comment is based on the information that was given on reactionary groups. And then to say, I don't think you need to inform us on the opinions of the reactionary groups, because they all had their opportunity to come and present before this committee, and they were treated equally. So what you were supposed to do was just present your own views on the NHI bill and stop there. Thank you.
Thank you very much, Honorable Chairperson. Let me thank Comrade Zola and his whole army of comrades, and most particularly Comrade Mbele for a very good presentation. As I said to the previous presenters from COSATU and from the South African Communist Party, I want to repeat and say that your presentation is very progressive and talks to the poor of this country. I'm therefore going to ask you this same question that I asked COSATU and the South African Communist Party. What is NEHAW's response to those who are opposed to the bill, in particular, and the NHI principle in general? Like what we have heard yesterday from AfriForum, and I think some weeks ago or last year from one professor, I just forget the name of the professor, that they will take government and this parliament to the Constitutional Court. Because according to them, this bill, when it becomes law, will not pass the constitutional muster. How does NEHAW take these threats? How will you and your members respond to these threats of going to block this noble cause, the cause of ensuring that the poor of this country have got access to quality and affordable health care like them, the rich ones? Of course, we live in a democratic dispensation which your organization played a crucial role to achieve. Everyone is free to go to court, including them. But now these noble causes are threatened in this way. What do you say in this regard as NEHAW? Then, Honorable Chairperson, my second question will be NEHAW has raised grave concerns about austerity measures that the National Treasury has imposed on the healthcare sector and the provision of public goods. What is NEHAW's proposal on protecting the funding that will be coming from the General Revenue Fund into the National Health Insurance Fund? Would NEHAW support earmarking if the NHI, would NEHAW support earmarking if the NHI budget. Please elaborate on this. Thank you very much, Chair.
Thank you very much. Sorry, thank you very much, Chair. I just have one question. What is the position on NHI contracting with the for-profit private providers to deliver services to be funded by the NHI fund? Thank you.
Thank you very much, Chairperson. Let me also welcome the presentation from NEHAU. Indeed, it's a progressive presentation, and we really welcome that and the support for the NHI, because you really know what the country is faced, and you know that you are fighting for the poor, and you know the challenges that the health sector is having. And also when you compare private sector and also the public sector, and what our government has done so far, the improvement in our health system, we know that at least we are moving forward to correct all the challenges that health department is faced, which I think NHI is a good move to make sure that we equalize the standard of health in South Africa, no matter whether you are poor or rich, but you'll be getting a quality health services in all health sectors, despite whether you are rich or poor, but will be getting a good health services in South Africa. Coming to the questions that I want to ask, NEHAU, what is NEHAU doing to prepare its membership for immigration into NHI? I'm asking this question because some detractors of NHI are saying what workers will be opposed to move out of GEMS into NHI. That is my first question. My second question, can you explain your experiences on how the countries that were post-war were able to implement their NHI? What lessons can South Africa learn from those experiences? Thank you very much, Chair. Siyabonga Maqabane.
Thank you, honorable members, for those questions you've raised to NEHAU. Are there any other members who want to raise any questions? Thank you very much again for your presentation to the GS and the team from NEHAU. I have a couple of things I want to raise with you. Now, we've heard many people express many different opinions over time as we have been having these public hearings. One of those is that government must first fix the public health system before the NHI is implemented. I'd like to hear what your view is with regards to the phased implementation of the NHI. And then secondly, the other one that we've heard is that monopoly power crowds out innovation. And your thoughts around this would be very welcome, both the positive and negative effects of this monopoly. And then your view also on the medical scheme providing parallel cover, meaning instead of providing complementary cover, what's your view on medical scheme providing substitutive cover? And then very lastly, in your presentation, you say you produced position papers on the NHI based on international benchmarking. What advice will you give to this portfolio committee on the obstacles to look out for of the country as we are about to achieve, wishing to achieve a single strategic purchase that will avoid fragmentation? Thank Thank you very much. Those are all the questions raised to you. You may proceed to provide some answers to those concerns raised by the members. Thank you.
Yeah, Chairperson. Thank you very much. My name is Sidney Khara. I'm the head of policy unit in Nahau. I shall try to answer majority of the questions which have been asked by members. And thereafter, my team will perhaps address the questions that I may have left out. I must say that these are many questions, more than we anticipated. So I hope in the process we've captured them very well. I think the first question was about the challenges with regard to the deployment of interns in rural areas, that they are refusing, as it was said, graduates are refusing to work in those parts of the country. Yeah, it is a challenge. I think there has been a discussion over time with regard to what incentives can be introduced that are adequate enough to entice practitioners to work in those parts of the country. But I also think it's an issue of the philosophy of the medical health. In other countries, notably in Cuba, inherent in the philosophy of the medicine or the education on healthcare is emphasizing actually starting and addressing in those remote, underprivileged areas. Whereas in our context, we know the hospice-centric model, the biomedical model we have in the South African context, which really create the orientation away from the underprivileged areas. So it's a long-term challenge we have, but I do think that with adequate training, sufficient graduating of practitioners, others may be able to decide to work in those parts. But we admit it's not an easy task because it's voluntary after all. There was a question about our views on austerity. Yeah, we've raised this consistently in the extent that it is really undermining progress that we can make in implementing the NHI. In the first instance, our expectation was that out of the COVID-19, the country can really realize more than ever before how important, the healthcare system is, and in particular, the centrality of the healthcare workers as doctors, as nurses, as porters, as all kinds of clinicians in the allied professional fields, as well as even security, that we can invest more so that we have some legacy out of the COVID-19 pandemic. So austerity is beginning to regress that. If you look at the medium-term expenditure framework, how much is going to be reduced, and in particular what Slindila was raising with regard to the location of the health spending as a fiscal risk. It's clearly counterproductive, basically saying that we are well already off track in implementing or achieving the goals of the NDP. And we do not want to accept that. And actually spending on health itself contribute in economic development. And we know all about how the multiplier effects, the healthiness of the workforce, et cetera, et cetera. What is the period? Yeah, we've been warned not to speak so much about detractors, but we shall, because they are standing in the way of the implementation of the law of the land. The Constitution expects government to ensure that all have access to healthcare. And there are people who oppose that. We reject that as Nahau, and we support the NHI. And we're not afraid to comment on what is there in the dominating us in the media, which is not a reflection of the 3 successive elections, by the way, in which NHI was put on the table, including the consensus that is there in the that was expressed in the national summit, presidential national summit on health. There's a question about the 400 billion that is spent in the private sector. What is the view of now? Yeah, imagine the 16% of the population, around 9 million or so, if it was one country where it spends this amount of money on healthcare, but at the same time manifesting the kind of health outcomes we have, even for people who are using the private health industry. This is a massive waste of resources, massive amounts of inefficiencies and failures, frankly. It's also because we mimic the United States health system. And you can also see that the United States is very low in the international comparison of performance of the health system in relation to the OECD countries in terms of health outcomes. So, in fact, if anything, what you find, and I'll advise the members to go read, especially those who speak about the private sector as if it's a good health system. They must just read the report of the Competition Commission. What it says about the inefficiencies in the health system there, in the private health system. So, yeah, that's our response to that question. Do you agree with the President's sentiments regarding the NHI? Certainly, 100%. And we're happy that the government continues to be committed in implementing the NHI. But we want to see more action supported by funding in relation to the next phase of the implementation of the NHI. Our analysis of the medium-term strategic framework of the Department of Health indicate that we could be doing more in preparing for the implementation of a law that is going to come out of this bill. Yes, we agree, NHI, in relation to what the white paper says, represent a massive shift, not only in terms of resources, but even ourselves in our orientation towards health. You know, because the NHI framework in terms of the policy emphasizes primary health care. That health, in fact, is the primary health care is the foundation of the health system, and therefore work on preventative promotion and so on are important in making our NHI sustainable. Then there was a question from Ms. Ishmael. Yes, we support the single purchaser, single buyer. That's the whole logic of pooling healthcare funds so that you can be rationalized and not be wasteful as we have in the private sector at the moment. But also you can cross-subsidize the poor who may not have the resources to access healthcare when it is a right. It's not a commodity. So we support that 100%. Yeah, and obviously the white paper proposes a shift in the purchasing model, and we support that. And other countries that are successfully implementing the NHI, I mean, their own universal healthcare systems are actually doing that. We are just an outlier together with the United States with using fee-for-service model. The issues around political interference, I don't know, I mean, that's more hypothetical. I don't know why would there be political interference, for what purpose? So I'm not sure what was expected to say about something that is supposed to happen in the future, according to the member there. The taxpayer carrying the bill, yes. Every country that has a universal health insurance, just like with any aspect of the tax system, the high income taxpayers really subsidize the poor. I mean, that is with regard to everything in a civilized country. So that will happen with also to health. It can't be an exception. So I don't think there's a problem. Anyway, the poor have been subsidizing the rich in this country, you know, with our history we have, where people were within the same occupations were paid differentially. And we did not have any benefits like health or retirement insurance. So it's not even an issue of pay that question. Yeah, the argument is an old one about the first you must fix the, I think the chair also raised it, also of you. You must first address the situation in the public health before you move into NHI. It's as if these things can happen sequentially, because the problem is that the situation in the public sector, yes, is a function of a whole range of challenges that are existing in terms of governance, in terms of budgetary allocation being inappropriate or inadequate.
Please
and
hold
also,
on.
as we also saw in the past 2 years.
Somebody, please, whoever is talking.
But the public sector is unable to progress while it is systematically parasitically siphoned off by the private sector, whether it's in terms of personnel, training, subsidies, we spoke about it adequately, and especially the professionals who, because of the existing wage premium in the private sector, people then move to the private sector. So you have to be able to address all of this at the same time, because pooling the resources of health into one pot, the NHI fund, creates a platform for you to be able to do that in an integrated way. And I think many people also would welcome that who are currently using the private sector, see the improvement over time in public health, so that they can choose to rather use their public health hospitals nearby, especially in the townships and rural areas. The question of freedom of choice is very abstract. It's not about freedom. You can only have access freedom if you have the means to do that. So when you say freedom of choice, you're talking about those who have the means to exercise that freedom. Whereas the makers of a constitution understood that not everyone will have access, and therefore the state must do something to address that, so that they can actually have the fullest expression of the freedoms of the country. So I don't think we can talk about freedom of choice in that limited way, where it's only for population. Unlike the member, I don't think I agree that the private sector is accountable, is corruption-free. If you just have to look at what has transpired in the commissions, on the commission, is the state corruption linked to private sector? I don't know what we're talking about, accountability in the private sector. If you read the report of the Competition Commission on the health market inquiry, gross violation with regard to collusion of the private sector players and how they abuse the sick, as we say in our submission. So let's not live in a different world from what we're experiencing in our country. There has to be accountability in the NHI fund. If a board is created, because in the white paper it was a commission, but if it's a board, it must be also accountable, but broadly representative of sectors. And as we say in our submission, including expertise around labor relations. Then there were questions about international benchmarking. I mean, there are many countries that have been making progressive shift to the universal health coverage, including in the African continent that we are noting in Ghana, but they've been Thailand and in the recent past, and some strides in Brazil and so on. So these are successful countries, and the world is united, as you can see with the resolution of the WHO in their assembly. The majority of countries favor universal health coverage. Hence the UN the sustainable goals that they've outlined for most countries. And we don't think that there will be any job losses. I think there should be, instead, if you create the NHI, there'll be more employment in the public sector, because currently we have a whole range of different types of vacancies because of limited resources that are diverted to the private sector. The one we don't support VAT on NHI. VAT is inherently regressive. That won't be able to shift the structure of our tax system in a way that enhances access for the people. Yeah, the member, I think Dr. Thembekwayo spoke about the situation of temporary workers in the Eastern Cape. Our union has been actively engaging with the department on that. We are of the view that actually these workers were employed not because they were additional, but actually there were already gaps or vacancies that needed people to fill them in. So it's unfortunate that the Treasury is committed to this view that there should not be any permanent commitments outside the fiscal framework, which is why we have a problem of that nature. And in fact, we may have a problem going forward in other provinces. But our view is also that we were able to raise funds recently, obtain a loan on favorable terms on the basis that it will help with our recovery of the health system and economic and the economy. And these are some of the interventions government should be able to use the money for that people. Because we're still under the state of disaster, and we couldn't be sharing jobs when there's a possibility of still other waves of the pandemic. Then there was our view on those who are opposing the bill. I mean, we've been working on the NHI campaign for some time now, and generally the views, we understand them, but they are stale views generally. So I said that before, that we are not afraid to express our views on the detractors of the NHI. And how proposal on protecting the fund does now support earmarking NHI for. Yeah, this is a more difficult question. I think, to be fair, I think the reality is that the Treasury is vehemently opposed to earmarking in terms of the budget allocations. But the question is about commitment. If government has a clear strategic commitment and a plan to implement the NHI, that would mean the plan is supported by the funds that are made, allocated, or if you like, earmarked in a way. So I think for us, it's not whether or not the earmark is the issue, is whether there's a commitment and backing that commitment with a plan and making funds available. What is NAHAU doing in preparing membership and workers who would like to remain in GEMS? That's a question by member Ms. Kela. We've been working on for some time now, especially amongst our members with education, within the limits of our resources. I think we've had NHI almost in every regional, provincial congress or workshops we've had, including even our participation in the parliamentary hearings in provinces. We often involve our members. I think it is true that there is a section of the public service workers that is skeptical about the NHI, only because also in the general public, many people do not understand that South Africa actually is strange in the world with what we have, with so many expenditure in private health and with the medical schemes we have. So I think if there would be more great strides shown in the implementation of the NHI and people beginning to see the benefits, more and more people would move or change their opinion. But the NHI is not an option. You can opt out once the fund has been established, but you then have to lose out on the benefits of being in a common pool. So over time, people will realize the benefits of the NHI as opposed to the current system, because you can actually compare countries that have universal health coverage and those that do not, and see the difference that it makes. But yeah, it's a challenge in educating workers in our sector, but also in the public in general. The post-war experience, how can SA succeed? Yeah, I mean, our emphasis here is a lot of countries, especially in Europe, but also elsewhere, were able, on the ashes of the war, to rebuild, and they used spending on health, in establishing infrastructure, in training personnel, in developing health industry, in terms of devices and pharmaceuticals, to rebuild their economies. And we can also be able to do that in South Africa. I think there are pioneering countries that across the board you'd find the whole populations are proud about their achievements from that period, notably Britain, but also other countries in mainland Europe. We can also follow that, but as I indicate that there are other countries in the global south that are doing the same, that we can also follow. Obviously, every country, approaches universal health coverage from its own particularities and experiences and challenges. And we have our particularities more so in South Africa that we have to take into account to be able to succeed. But we certainly have the potential to succeed. There's no question about that. Then the chairperson asked about government. Oh yeah, we responded to that question about fix the public first and so on. Monopoly power of the fund crowding out innovation. I'm not sure about that. I don't see how the innovation spoken about would then be universally applicable to people without access in the current arrangement of medical schemes. I mean, the criteria of any alternative that is being proposed, or for those who are rejecting the NHI, must understand, if they are going to oppose the NHI, their alternative must provide an answer on the question of how to achieve universal health coverage, how to meet the constitutional requirement. Then I don't think maintaining the current multiple schemes that deprive us of an opportunity to transform the health system would lead to innovation in a specific way. I'm not sure how that works in the context of universal health coverage. We can't stop implementing the NHI just because we think that there are certain innovations that we can miss out that only benefits a few people in the That doesn't make sense. Yeah, I've indicated that the NHI is going to be a common pool for the entirety of the nation, compulsory. But the white paper does provide for people if they so choose to opt out, but at their own cost. So I think we cannot have multiple funds existing anymore in the particular, and even that has been shown to be unsustainable, as there's been a lot of consolidation, and others have been closing over time since the 1990s. Yeah, I think, Chairperson, I tried to answer the questions as much as I can. I don't know whether, Stilo, you have any question. If Jess and Comrade Tengo also want to add, they would do so, Chairperson. But from our side, thank you very much indeed. Thanks.
Any other responses from your team?
Thank you, Chair. Just on 3 questions, I must say this, it would have been a good thing to engage with you if we had time. But because we're working within the constraints of time, I will be short and dealing with these issues. The first issue is attracting health practitioners in rural areas. 2 things that we want to raise for consideration by the committee or portfolio committee, yes. That one, there are lessons to learn from and improve from those lessons. For instance, there is a model used by education to attract teachers in those areas. Why don't we look onto that model and take what might be relevant and strengthen that model to our own context, because we need that kind of a service in those areas. That's the first point that we'll do. Balancing that is the curriculum that we're providing at schools, which lacks revolutionary moral aspects that makes a student who becomes a graduate to appreciate that we have a social responsibility to serve our nation. So we do think that those 2 aspects combined ought to be looked into. We would have, if we had time, to share some experiences in that context. But as long as we have an education that produces graduates for market, it will not going to be easy to have people volunteering and working under or in rural areas, because the logic of market is nothing for free. So that's why it's so difficult now. That's the first point that we want to make. The second point, it relates to Office of Health Standard Compliance, which has a responsibility to ensure quality and safety in health. I do think that, Chair, would be making a mistake if we look on matters of compliance in the context or in isolation with national health insurance, because South Africa has a general challenge of compliance. For instance, the institution of lawmakers, in this case Parliament, also is a culprit in complying with the same law that they produced. Secondly, institutions of government in the form of department, they are also particularly the custodian of the laws, for instance, of the occupational health and safety through the Department of Employment and Labor, is found wanting, actually, is the first culprit to be arrested, if truth is to be told, because there's no compliance, not only in health, across sectors. Completely now, there is no compliance with the establishment of health and safety committees in all workplaces where our members are. And evidence to that is a report that we publicized in July 2020. We call it fact findings, which really was looking in the hospitals in the context of COVID and how South Africa has positioned itself to respond to that. And that report, we made it public. We have submitted to the president of the country, ministers, deputy ministers, and members of this portfolio committee. Unfortunately, nothing has been done even to look into those findings and proposals made. So it's a general problem. So when we look into the issue of Office of Standard Compliance, health standard compliance, we must look at it in totality in the overall context of general lack to comply by institutions that to be custodian that should have acted as example and bring confidence in the nation. So that's the point that we say that unless we look at it in broad terms. But when it comes to health standard compliance, that office, we do think that we should undertake a review process, particularly on the role and powers. Because if you give an office, if you give an office a limited powers on compliance, you might not achieve what you have set for yourself. Secondly, we must address the structural and power relations amongst departments, because that office wouldn't do anything without the Department of Employment and Labor as part of enforcing compliance. So we need to look into those issues, Chair. The third point, Chair, our members, in that question, what are we expecting to do or expected to do? Our members, as I said earlier on, are more ready to defend the NHI at all costs. If needs be, we'll use all our resources to defend it, including mass mobilization, not only workers, but society as a whole, precisely because health is a societal issue. We're more than prepared to do so, using our resources, our personnel to mobilize society to defend, because that's what we understood as NEHAU as a real component of what we called the second phase of our transition. Introducing national health insurance or having it speaks to that second phase of our transition. So we'll do everything, Chair, to defend the national insurance, noting the contending views which we respect, but we'll continue. That's why we have raised their views here, because we are more committed even to engage and persuade them to realize the importance of the national health insurance as a solution to justice and fairness of society. Thank you very much.
Thank you very much. Anyone else from your team, General Secretary? No one?
Chair, there was a question about the question of how to address the provincial disparities in terms of the healthcare workers. Yeah, we didn't answer that question, but we know that it's part of how the human resource for health strategy, which has been recently adopted, seeks to address in terms of how the training and allocation of resources will also respond to the disparities as they exist in different provinces. But provinces also are affected by that question about the tendency of, practitioners or graduates not wanting to work in rural areas. I think that we think that the human resource for health has an intent to address that particularly well. My last point is that we note and we're quite surprised that nobody has asked us a question about the Competition Commission report in relation to the private sector, but also about the tax expenditure subsidies that deprive majority of our people access to those subsidies. Thanks, nonetheless, Chairperson.
Thank you very much. We appreciate you coming to present today to the Portfolio Committee. We have noted your inputs and your concerns and your recommendations. We will take that further as a Portfolio Committee. If you want to make a very last comment, you're very welcome to before we move on to the minutes, which we still need to deal with for consideration and adoption of prior minutes of this Portfolio Committee.
No, thank you very much, Chair. On our side, we're fine.
Thank you very much once again. We appreciate you coming. Honorable members, we have come to the end of the presentations on the NHI public bill for today. We still have a couple of other items we'd like to complete today. We are aware that some of our members would like to catch the bus that leaves the parliamentary villages at 12:30. We will try to do only maybe 2 or 3 sets of minutes as time allows and take the other minutes to next week. Ms. Majalamba, are you ready for us?
Yes, Chair, I'm ready. We'll first start with the minutes of the 25th of January. Thank you, Chair.
Thank you very much. Honourable members, you have received these minutes and it's been forwarded to all of us. Hopefully you would have had a look at it and we'll be able to move through these very fast. So the minutes of the 21st of January of the Portfolio Committee on Health, page 1. Make certain that you are noted to have been present or to have on page 2 have tendered your apology. And page 3 was a presentation by Bonitas. Anything you want to add? Can I move on?
I didn't see page 1. Sorry, Chairperson, I didn't see page 1.
Page 1, you are there, Honorable Munyai?
No, I'm here. Thank you. I just wanted to check that. You can move now to page 3.
We are at page 4. So then we have the anything from the minutes that you had picked up, honorable members, that you'd like to speak to. We now with page 5. And going on to page 6.
Doctor, my computer battery it's nearly finished. It's finished. I don't have a charger here with me.
It's fine, Honorable Munyai. Thank you very much for informing me.
But I support the course, and I would have moved for the adoption of all the minutes.
Thank you. You have now moved. Are you moving for adoption of these minutes while you're here?
Yes, I'm moving.
Thank you very much. Can I get a seconder for the adoption of the minutes of the 21st?
I second, Chair. Chairperson, I'm seconding the minutes.
Thank you very much, Honorable Gela.
Let's move.
Minutes are therefore duly adopted. Honorable members, we will go on to the minutes of the 26th of January, page 1. See if you're present. Page 2, whether the apology is noted. Page 3, yes. Did I hear a voice? Page 4. We've seen the list of stakeholders, page 4. Page 5. Page 6. Page 7. Page 8. And page 9. Honorable members, can I get a mover for the adoption of these minutes?
I so move, Honorable Chairperson, that we accept the minutes.
Thank you very much, Honorable Sukacha. Can I get a seconder for the adoption of these minutes to the movement of Honorable Sukacha?
I'm seconding, Chairperson.
Thank you very much, Honorable Gera. Ms. Majalamba, shall we do a third?
Yes, Chair, please. 28th of January.
Thank you very much.
Thank you, Chair.
28th of January, honorable members, page 1. Note again whether you're present. Note it as being present. Page 2, apologies. The health department and the officials or support staff's presence. Page 3. We had a list of stakeholders, Competition Commission, Commission for Gender Equality, Solidarity. Page 4. Page 5. page 6, and then page 7, and then lastly page 8. Thank you, honorable members. Can I ask for a mover for the adoption of these minutes?
Chairperson, I move for the approval of the minutes.
Thank you, Honorable Gela. Any seconder to that movement?
Chairperson, as somebody who was actively participating on that meeting of the 29th of January, I hereby second.
Thank you very much, Honorable Sukacha. We appreciate that. We have 2 sets of documents still outstanding. We can quickly move to them and finish them. Yes, Honorable Remark?
8th February 2022.
Thank you. 8th of February, honorable members, same thing, page 1. You noted there, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, and the last page. Thank you very much. Can I get a mover for the adoption of these minutes?
Chairperson, I move for the approval of the minutes.
Thank you, Honorable Gela. Any seconder?
Chairperson, I second the minutes.
We'll go to the last, that minutes are duly adopted. We will go to the last set of minutes which have been prepared of the 9th of February. Page 1, you all noted there. Page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9. Any mover for the adoption of the minutes?
Chair, I've read through the minutes and I hereby propose that we accept the minutes.
Thank you very much, Honorable Sukacha. Any seconder to the movement of Honorable Sukacha?
Chairperson, I second the approval of the minutes.
Thank you very much. Those are the last minutes, I think, Ms. Majalamba, that we have prepared.
Yes, Chair.
Thank you very much. Honorable members, thank you very much for spending your morning with us. We had a wonderful day, wonderful presentations. We are looking forward to completing the NHI public hearings next week. From the National Assembly's point of view, we will be having presentations on the 23rd. And enjoy the sitting for the rest of the day, and our meeting is therefore adjourned. Thank you.
Alibongwe.
Alibongwe.
Recording stopped.
Siyabonga, Chairperson.